Hi, this is Brian Wormers, and today I'm going to be talking about inflammatory intestinal disorders for medical surgical nursing. Some of the main objectives for this are going to be talking about appendicitis, peritonitis, gastroenteritis, IBD, diverticular disease, celiac disease, and then parasitic or helmonithic infections. So appendicitis, this is common. I'm guessing most of you have heard of this before, but this is inflammation of the variform appendix, which is that little hangy downy thing on your intestine. It's the blind pouch attached to the cecum at the end of the colon. So most common cause of right lower quadrant pain, specifically at McBurney's point, which is a third of the way between the umbilicus and the anterior iliac crest. This is often related to rebound tenderness, and that's a big sign associated with appendicitis, is that you push on this and it doesn't cause pain when you push on it, but when you let go, then that's when it hurts. Although you do have to be careful, because if it gets perforated, there's no more pain, but the patient will get septic relatively soon. So that's a really big red flag that stomach was hurt and you had all the signs of appendix and now it's suddenly gone. They might be better for a little bit, but be very careful that it's probably going to lead into peritonitis and sepsis. Non-surgical management, so we can make them NPO for the possibility of surgery, IV fluids to maintain hydration, put them in a semi-Fowler's position for comfort, analgesics for pain management. Do not give anything like a laxative or enema, because when that appendix is irritated and you try and stimulate it, it might lead into a perforation. Do not put heat on the abdomen, because that increases the inflammation. It's just like if you get a twisted ankle and you heat your twisted ankle, it makes it worse. If it becomes perforated, what we can do is start antibiotics, so ciproflagyl, and then allow that to encapsulate and operate in 6 weeks on an outpatient type of situation. If this is encapsulated already and they're having a cyst and complications related to that, then we can go to interventional radiology. They can drain that, and then we can start the antibiotics as well. Usually surgery is not emergent, but it needs to happen relatively quickly. So there's a difference. Doesn't mean to be like overnight, drop everything you're doing and get them in, but it does need to be done in the next couple of hours type of situation. So if diagnostics is not definitive, then we can do exploratory labs to rule out appendicitis. For peritonitis, so this is life-threatening. This is an acute inflammation of the peritoneum, and this decreases peristalsis. They get a rigid board-like abdomen, and this is bad. If you ever hear this is something not to take lightly. They get abdominal pain, distended abdomen, high fever, tachycardia, dehydration, low urine output, hiccups, compromised respiratory status, nausea, and vomiting. With this, they're at high risk for sepsis. Physical findings are going to depend on how sick that they are, but most of them look sick. They're going to lay there still. Knees are going to be flexed because their abdomen hurts. They'll have signs and symptoms of pain, and that board-like abdomen is a big key for this one. If you do CBC, you will see that their WBCs are elevated. Treatment for peritonitis is going to include IV fluids, broad-spectrum antibiotics. Usually this is cipro and flagyl. We might do daily weights just to monitor how they're doing. Of course, we're going to watch fluid volume. Might do an NG to keep that stomach NPO and keep the stomach contents out of there. Might place them on oxygen if they need to. Pain management with different medications, and usually this is going to be an opioid type of therapy. And then surgery if all else is kind of failing with this. But we can do exploratory and see what's going on with there. We can do irrigation, so rinsing out everything and try and rinse out the infection out of there. But these patients after this tend to get kind of sick. They don't usually like this surgery very much. Postoperative, of course, wound care, semi-Fowler's position, supportive care, pain management, IV fluid replacement, and then wash those incisions and drains. Gastroenteritis, so this is a stomach ache, stomach upset, so increased stool and vomiting, usually self-limited, can be bacterial such as like Shigella, E. coli, Campi, Could be a viral such as Norwalk, could be, just is. One thing to ask about any recent travel. Have they been to a new area where they've been exposed to new bacteria? And that can be the cause of it. Other things that will go along with it: muscle aches, headache, malaise, signs and symptoms of dehydration because they're puking and stooling. Interventions, of course, fluid replacement. So this will probably be an IV fluid. If the stomach is irritated, you probably don't want to drop an NG down and give fluid that way. And then give nutritional therapy. Drug therapy, you can give antibiotics if it is a bacterial form, such as Campy or Shigella. Be very careful that we don't always give it with E. coli, especially if it's, and we'll talk about this later on, but this can actually damage your kidneys if you treat E. coli with some antibiotics. And then warning with antiemetics, try not to. If your body's trying to purge the system, let them puke it out, poop it out, instead of trying to keep that organism in there. Because if you do, they're going to be sicker, and they'll be sicker for a longer period of time. And then, of course, skincare. So with doing those things, make sure that if they're having increased stooling and vomiting, that we're monitoring that skin and they're not getting breakdown. Ulcerative colitis is a specific form of inflammatory bowel disease. This is widespread, mainly through the rectum and colon, but it can be the entire colon. So big point with this is colitis happens in the colon, so that's where this is occurring. Loose stools, so is your symptoms. They're bloody, mucousy. And as a result of that thickening, you're not getting absorption of nutrients and fluids, and so your patient's at risk with that. Over the long run, they are at risk for colon cancer because of that irritation chronically. History is going to include family history of anybody else that's got UC. Physical assessment: low-grade fevers, tenderness of the abdomen with palpation, tenesmus, which is an unpleasant and urgent sensation to go to the bathroom. And then it often is better when they do. Psychosocial assessment: this is kind of disruptive and stressful to their life as an understatement. Laboratory assessment is going to include an H&H to see how much they're bleeding. WBC to look for inflammation with the markers of CRP, ESR, and check electrolytes if they're not absorbing things well. Diagnostic tests: we'll do a colonoscopy and look for definitive signs and symptoms of UC. And then there's biomarkers that we can do as well. Treatment: aminosalicylates. So mesalamine is one of the things that we'll do to try and calm down that treatment. We can give steroids. Be aware that for long courses of steroids, we will taper that at the end so we don't have long-term complications and adverse effects of the Cushingoid syndrome. Immunomodulators trying to calm that body down, such as Remicade or Humira. Antidiarrheal drugs. We want to be very careful in this case. We don't always give these because they are at risk for distending their colon and getting a toxic megacolon, and that's bad. Nutritional therapy. So, of course, when severe, we make them NPO, give them some TPN and lipids, or even transfer them into a low residue diet, reduce lactose containing foods. Give them some rest physically and emotionally, and let them heal. Now, be able to tell and distinguish between ulcerative colitis and Crohn's disease. They're both very similar, and they can present very similarly. Crohn's disease is an inflammatory disease of the small intestine and the colon, or both, but this can occur from mouth to anus. So realize that this is more widespread. It is both an inflammation. It causes thickening of the bowel wall. Crohn's disease is more likely to have fistulas, which is a big difference between the two. As a result of the irritation, cancer can develop, but it's not as common as what it is with UC. Malabsorption of the vitamins and nutrients is more concerning with this because it's of the small intestine. Drug therapy: so similar to UC, some steroids, so trying to calm that body down with steroids and the immunomodulators and all those other meds that we talked about. Nutritional therapy: Once again, bowel rest and TPN. Fistula management. Oftentimes, if we can control that and start them on the steroids, then the fistulas and stuff like that will heal up. The fistulas can be from the intestine out, leaking out through the skin, like in this case, or it can be between this, or I've seen it between the intestine and the bladder, and it presents as frequent bladder infections and UTIs. Other things we can do: fluid and electrolyte therapy. Of course, we want to keep them hydrated. Skincare, want to watch for breakdown, prevent infections, and then surgical management if we absolutely have to. With Crohn's disease, it's very rare that we'll do surgery on this, but it's theoretically possible. Diverticular disease. So this is where you get outpouching. So you get this little bit of an outpouching here. And the bad thing about that is seeds and other fecal matter can deposit in there, cause irritation, get blocked, and then it causes a lot of irritation and complications. So it's a herniation off the wall of the intestine. Risks include they're at risk for infection, bleeding, scarring, obstruction, fistulas. If they get something stuck in here, it can rupture and cause peritonitis. So this is something that can be severe. People are at a higher risk for if they've got intermittent pain, constipation, fever, nausea. Physical assignment or assessment is going to be, uncomplicated diverticulosis might never have any manifestations. Statistically, probably somebody in your class has got diverticular disease, and then you might not ever know it. If they are having signs and symptoms, it's going to present with abdominal pain, nausea, vomiting, fever, chills, and tachycardia. Often they, might have a distended belly and some peritonitis if one of these ruptures. Diagnostic assessments are going to include WBC, looking for white blood cell elevation, a decreased H&H, and we can also do radiology of an X-ray and colonoscopy. Treatment, so, fiber therapy, trying to get things moving, but avoid seeds, like the seeds on the hamburger buns, corn, popcorn, the seeds of strawberries, those type of things. Provide bowel rest, correct any dehydration with IV fluids, give IV antibiotics so we don't get a peritonitis. Can use anticholinergics with this, analgesics to try and control the pain. Make them NPO if we have to. Avoid laxatives and enemas because we don't want to stress out that the intestine. Patient is at risk for peritonitis, pelvic abscess, bowel obstruction, fistula, fever, uncontrolled bleeding. Those are all side effects of this going badly. If that happens, they might have to do surgery, resect it, and then sew it back together. So celiac disease, I'm guessing that you've heard of this, but this is related to ingestion of gluten. So this is a multi-system autoimmune disease of the small intestine that has the signs and symptoms of anorexia, diarrhea, constipation, staturia, and weight loss. Diagnostics of this, we can do some lab work to figure out if they have celiac disease. With this, keep the gluten in their diet so that they become positive when we test for them. And then, of course, management is including a gluten-free diet. Last slide here is parasitic and helmonithic infections. So this is a parasitic infection. So if you kind of click on some of the stuff, you can see some different images of this. It's usually spread fecal oral, or we kind of eat it as a result of undercooked food or contaminated water. Assessment, so where have they been? What have they been around? Have anybody else have these problems? GI symptoms for all these can be diarrhea, cramping, fatigue, weight loss. You might see some itching of the peritoneal. With pinworms, you might be able to use some tape around the anus and trap some of these or stick some of these. For tapeworms, you might see them in the stool. But regardless, we can give medications to try and clear those up, and IV therapy for hydration and keeping them well hydrated during this situation. That concludes this presentation. If you have any questions, please contact your instructor.